So this is a both column acetabular fracture, and here we have the three views: the AP, iliac view, and obturator view. So on this view we can see the fracture coming from the iliac bone, iliac crest, going down to the iliac fossa, and then running into the inner pelvis. There is also another anterior column fracture here, and the ramus down here. In the iliac view, we can again see the fracture running from the iliac bone, coming down, and we have this typical spike here. Sometimes there is a triangle, a separate triangle fragment here. Again, the anterior column fracture coming to the quadrilateral surface here, and also the posterior column. The obturator view, we can see again the iliac bone view, iliac bone fracture going all the way down, and also this additional anterior column fracture, and the ramus broken again. So the idea is to draw a fixation according to the lateral principle. So we'll perform a ilio-inguinal approach and develop all the three windows, the first, the second, and the third window. And first of all, we will fix the iliac bone, this fracture and this fracture, and then we will reduce and fix the additional anterior column fracture, and then fix with a plate that comes from the iliac bone, just lateral from the sacroiliac joint, and go into the ramus. And lastly, the posterior column will need to be reduced with some kind of technique, usually using some kind of clamps, like meta clamps or something like that, and then fix the fracture with screws coming from the plate, or sometimes out of the plate, and trying to reach the posterior column. Sometimes the screws can come all the way down here, going to the ischium. So this is the first step of the fixation. So we should start with the iliac crest, reducing with some kind of clamp, for example, a Weber clamp or a ball spike pusher to help, and also reduce this area here. Sometimes an interesting clamp is the queen tongue, where we can do like a small incision here and introduce one of the tongues of the clamp here and the other two here, and reduce this area. So once reduced, we can fix with a plate, like on the top, or sometimes inside the pelvis, or just with some screws. I just put 2 screws here, and also here a screw to hold this reduction. It's important to remember that sometimes we can have like an opening of the SI joint. So in this case, we should first of all reduce and fix, usually with a very short plate, to avoid getting in the way of the main implant that will go from here to here. So next step would be reducing the other areas of the anterior column, like here, for example, and then sliding a plate here from this area, just lateral of the SI joint, going all the way behind the iliopsoas and femoral nerve and the vascular bundle, and if male, the spermatic cord or the round ligament in females, and coming this area where we have a solid bone and applying at least 2 screws. Important to remember how this screw can be sometimes on the way, so important to put the plate in an exact position. So In this view, you can see the same, and in the obturator view, again, the plate fixing the anterior column and also helping fixing this high anterior column. So the final step would be reducing and fixing the posterior column and also the quadrilateral surface if they are not in the same fragment, usually using some kind of clamp, Mata clamp, or a bone hook can also help, and then maybe fix with a K-wire, and then should use screws through the empty holes that were left, aiming usually the sciatic notch or the sciatic spine, which is around here, or even the issue tubercle. If the angle is not ideal, you can also shoot the screws from this area out of the plate. Important to remember that this is the most traditional technique described by Litronel, but you can also apply special plates or even use internal infrapectineal plates if you want. Again, important to remember to check if there is no implants going into the hip joint. Usually with this iliac view, you'll be sure there are no implants.